Okay, good morning. It's 8 o'clock, so we're going to get started. I just want to remind people that clinical research mentorship program from the Libin is up and running. It's open to all Libin Institute clinicians, nurse practitioners, nurses, and trainees. And if you get selected, you will be matched with mentors and take part in 5 sessions between June and December of this year. That hopefully will get you some skills to do some research. This will be sponsored by the Libin and a grant competition at the end of the program. Deadline for registration is there, May 24th. And if you want to learn more, you can click that link there, or you can point your camera to that IQ code thing. So make sure you try to look into this and be part of the clinical research mentorship program, which I believe is going to be really good. There's going to be some very well-known national and international mentors for you guys to take advantage of. Okay, so that much for that. And if you want, Omid, you can share your screen, and I'll briefly introduce Dr. Kiamanesh, who is a cardiologist that's specializing in advanced heart failure and echocardiography. He completed his internal medicine and cardiology residencies at the University of British Columbia, where he was a chief medical and chief cardiology resident. He completed a fellowship training in advanced heart failure, mechanical circulatory support, and cardiac transplantation, followed by advanced echo at the University of Toronto. And he's currently a clinical fellow in advanced echocardiography here at the University of Calgary. And he will be joining our troops hopefully July 1st. So it's a great pleasure to have Omid around, and you can take him from there.
Great. Well, thank you, Dr. Murillo, and thanks to you all for this opportunity to share with you a topic that I find very interesting, which is how we can increase our supply of donor organs. And I have no relevant disclosures to make. So transplant really is the treatment of choice for patients with end-stage organ failure. And in the case of heart transplant, advances over the past 50 years have resulted in really excellent long-term outcomes. So you can see here, we found a local median survival of 16 years following heart transplantation in this single center study. And I think in part because of such great outcomes, rates of heart transplantation really took off in the 1980s. But then you can see they kind of plateaued for 20 years or so. And the major limitation has remained a critical shortage of organs. Meanwhile, our wait lists continue to grow, and they expose our patients to unacceptably high waitlist mortalities. So it's actually estimated that half of all Canadians who are listed for a transplant will never get an organ. Of these, 1 in 3 will die while on the waiting list, and the rest will deteriorate until they're no longer deemed candidates for transplant. In 2016 alone, 260 Canadians died while waiting for an organ. And in the case of heart transplant, our waiting lists average nationally about 120 persons per year, and they're associated with an annual death rate of 11%. In recognition of this, the WHO has called on governments to increase their rates of organ donation. And while Canada's deceased donor rate of 22 is improved and respectable, it's still less than half that of Spain, who leads the world with a rate of over 47 per million persons. So I think it's our responsibility to increase our donor rate, and it's through policy change and scientific advances that we can do so. The objective of this talk is to give an overview on the policy and science that can increase our availability of donor organs. And it's sort of split into 2 sections. So in the first half, we'll discuss 3 policies to increase the donation of organs. And in the second half, we'll discuss some scientific advancements that have allowed us to increase our utilization of organs. And at the end of each policy, I'll give you my take. And by the end of this talk, I hope to have provided a balanced view on what I think are some of the most controversial and interesting topics in both medicine and society. In doing so, I've viewed each policy through what I consider to be the best guiding principles. And this is nicely laid out by Dr. Robert Truog. So that is to save the most lives as ethically possible, to protect and respect the organ donor, and to maintain the trust of the public. Okay, so we're going to start with consent policy, which is really one of the oldest and most public debates in transplantation. When surveyed, 95% of Canadians support organ donation, and more than half say they've actually made up their mind to donate. But despite this, only 20% have actually registered their intention to do so. Now, these numbers are comparable to consent rates observed in a handful of countries. They're actually very different from these other countries who boast a consent rate of about 99%. Now, I think we're all sort of tempted to assume that these differences are due to maybe different religious, cultural, and social perspectives on transplantation, but if you rearrange this graph, you'll see that countries with very similar beliefs have very different behaviors. And this is nicely shown by Eric Johnson and Dan Ariely. So just compare from left to right, Denmark and Sweden, Netherlands and Belgium, United Kingdom and France, Germany and Austria. Why are they so different? Well, it turns out that the countries highlighted in red have an opt-in policy like Canada, whereas the countries highlighted in blue have an opt-out policy like Spain. In an opt-in policy, the default assumption is that you do not wish to donate your organs. And so you actually have to opt into the system if you want to donate. Whereas in an opt-out system, the default assumption is that you wish to donate your organs. So you have to opt out of the system if you do not wish to donate. And this actually has a really big impact. So when surveyed, 40% of Americans actually had a different donor decision based simply on the way the question was phrased. And so you have to ask, why are we so influenced, so easily influenced? Now, some think it's apathy, right? I mean, after all, whatever decision you make is only going to be implemented after you're dead. So to some, it doesn't really impact you at all. But I think, in fact, it's quite the opposite. So most people find this decision to be so important and challenging that their response is actually heavily impacted on by the way the question's asked. We assume that people have these well-articulated donor decisions, but in fact, a donor decision is probably constructed and not yet articulated by those who have not been asked. We form our choice when we're asked, and it's based on the context and manner in which the question is presented. So this seemingly simple form-based question actually sets a default choice to a really complex decision, and that signals some important information to the reader. Number one, the reader may feel that the default is a recommendation by the policymaker. Number two, the default just feels safer. So when we make decisions, we prefer avoiding losses to an equivalent gain. So it's our natural tendency to stick with the default. And lastly, accepting the default is really effortless. Whereas to consider to donate my organs, I have to actually consider my own mortality. And that in itself is stressful and unpleasant. So I think what we can learn is that the narrative around organ donation influences our decisions. And interestingly, it can also influence our perceptions. So this is a great study where they showed participants a scale of altruistic actions ranging anywhere from minor acts on the left, such as voting for a mayor or paying for your taxes, things that we should all just do, all the way to very significant acts on the right, such as volunteering for a dangerous military assignment. Now, in a country like Canada, with an opt-in policy, organ donation is viewed as very altruistic. It actually ranks as comparable as giving away half of your wealth and nearly as altruistic as going on a hunger strike for a passionate cause. By contrast, you look at a country like Spain that has an opt-out policy, and organ donation ranks somewhere between volunteering with the poor and simply letting someone go ahead of you in line. So the take home here is that policies can actually normalize organ donation as a common act of good. And a number of countries have recently implemented these opt-out policies. This includes, as you can see, Wales, France, Iceland, and the United Kingdom. And locally, just 4 months ago, Nova Scotia became the first province to implement an opt-out policy in Canada. Now, it may be too early to draw a conclusion for some of these more recent countries, but I really have to stress that the policy has not increased the actual donor rate. And this is an important lesson. Okay, so while opt-out systems may increase the effective consent rate, they've never been shown to increase rates of transplantation. But what we learned from these slides is that how we frame organ donation will influence perceptions and behaviors. So we have to really ask ourselves, when when you're at the local registry and you've been waiting in line to renew your driver's license for 45 minutes, and then someone asks you if you want to donate your organs, is that really the most appropriate time to be phrasing that question? I think we can do better than that. And we really should be having these conversations with our patients and society in a manner that is much more purposeful and respectful. Lastly, Canadians are benevolent. They've already told us that they want to donate their organs. We just need to implement policies that allow them to do so while protecting their liberty and their dignity. So the next policy to discuss is compensation for organ donation. It's pretty clear-cut in Canada. A person must not buy, sell, or otherwise deal in valuable consideration for a transplant. Otherwise, this valuable consideration may corrupt altruism, commodify organs, and it can lead to exploitation. But many countries actually offer incentives to increase donation rates. So just by example, Iran offers money for organs, Israel offers healthcare priority, the United States offers healthcare and paid leave, and both Singapore and Chile offer healthcare priority. And I really want to highlight Iran and Israel because I think they serve as great case studies for donation incentives. And before we get into it, I just want to stress that the policies in each country were born out of a place of necessity and I think good at the time, okay? So let's start with Iran, where money is exchanged for organs. And the context is really important here. So international sanctions that followed the revolution resulted in a lack of access to dialysis and organ donation locally. So simply put, if an Iranian lost kidney function, they would either die of renal failure or they received government funding to go abroad for organ transplantation. But by 1988, the Iran-Iraq War had exhausted this funding to go abroad. And so Iran set to revive local donation by creating the only state system where people are paid to donate their organs. So in Iran, a living kidney donor receives healthcare for 1 year, and they receive approximately $10,000 US, which is negotiated with and paid for by a completely unrelated recipient. And with this policy, the country actually eliminated the waiting list by 1999, with 99% of these donations being paid and to unrelated recipients. Unfortunately, the policy has now resulted in the widespread exploitation of marginalized persons, and it's generally viewed as morally unacceptable. So what you're looking at here is for sale signs for human kidneys in Iran. And despite posting these signs, these kidney vendors will later report a lower quality of life, and 85% say they would not vend again. When surveyed, half of vendors were willing to give up more than 10 years of their life and the majority of their assets just to regain their kidney. So this is the problem with payment for organs. Israel had a very different situation where many Orthodox members of society viewed organ donation as a desecration of the body. They simply rejected it on principle. Yet they were still willing to accept an organ if they needed a transplant. And so the existence of these so-called free riders, it really discouraged other people to donate into this system. And it led to Israel having one of the lowest organ donation rates in all Western countries. Maybe even more worrisome is it led to widespread transplant tourism. So Israeli insurance companies would actually reimburse people to go abroad and seek a transplant, regardless of the legality in the local jurisdiction. So you can see the problems there. So to eliminate this practice and increase donation rates, Israel developed a new system that was really based on reciprocity. And simply put, if you agree to donate your organs, you would receive priority if you were ever in need of a transplant yourself. And this resulted in a record number of donor consents and organ donations. And I think it's really rooted in fundamentals that are both ethical and effective. But before we explain or judge the ethics of incentives for living donation, we first need to consider what motivates people to donate. So as humans, we make decisions that advantage us. And in the case of organ donation, most agree that altruism should be the only motivating factor. But this altruistic act is coupled with monetary and non-monetary loss. Okay, so monetary loss relates to, a donor's lost earnings, their expenses for travel and medical care relating to donation itself. Whereas non-monetary loss includes, pain, anxiety, and risk to a donor's health. And these are actually significant disincentives to donate. Now, we could try to reimburse these losses to remove the disincentive, as long as the reimbursement does not exceed the loss. If it does, then a donor will receive material gain from an organ donation. And that can be motivation in itself. And that will definitely corrupt altruism. And now this is kind of where Iran and Israel differ. So Iran pays organ donors, which can coerce marginalized persons, whereas Israel's system is based on reciprocity and more tries to offset their loss. And it definitely avoids material gain. Now, the effect of monetary and non-monetary incentives is illustrated by this really nice survey by John Gill. And so they surveyed people who were unwilling to become living kidney donors. And then they offered them $10,000 through the survey. And you can see that a large number of people are now willing to donate for $10,000. You can also see that they're more willing to donate based on the closeness of relationship with the recipient, which enhances their altruistic gain. So about half would donate to a relative versus only 6% to an acquaintance. The second chart demonstrates that more people are willing to donate for more money. So when offered $100,000, many more people were willing to donate. And this shows how monetary and non-monetary gain are directly correlated to a person's willingness to donate, and they're powerful motivators. So these are the key considerations for compensation for organ donation. So when providing compensation, we have to ensure that we do not undermine altruism. Okay, but we can still remove disincentives. So a living donor, they shouldn't have to pay money to donate their organs. Quantify and reimburse that financial loss to remove that disincentive. Non-monetary loss, pain, anxiety, risk to their health, is much harder to quantify and therefore more problematic to reimburse. Okay, and lastly, we must never coerce donors. I do think that coercion can be avoided by following these two principles. So number one, only losses should be reimbursed. And number two, reimbursement should be made in kind. So what I mean by that is money should never be given for non-monetary loss. The third and last policy I'd like to discuss is infrastructure for organ donation. And I'd like to go back to the opt-in, opt-out debate for a second, okay? So remember that Spain was the first country with an opt-out policy in 1979. But they actually didn't see an increase in their donor rates for 10 years until they rolled out this comprehensive approach to transplantation, which coordinates activities at the national, regional, and local levels. And this is termed the Spanish model, and it's actually heavily studied by other programs as a model for success. Their national transplant organization oversees any national decision on donation, along with a commission of 17 regional coordinators. And together, this executive committee has trained over 11,000 clinicians, and they work closely with the public media to really construct a positive climate toward organ donation. The hospital level is made up of 170 coordinators. So these transplant coordinators are actually critical care docs that work in the ICU, and they really serve as gatekeepers to donation, and they champion donation at the local level. And I've just highlighted this in green because when Canadian Blood Services studied the Spanish model, they actually concluded that this role of the transplant coordinator was the cornerstone of success. These coordinators conduct a continuous audit of all deaths occurring in critical care units, and they report directly to the hospital administration, not to the transplant team. The hospital, in turn, is reimbursed on a performance basis. Okay. This Spanish model led to a doubling of the deceased donor rate in Spain over a 10-year period. And in Croatia and Portugal, the use of a similar model increased donation rates by 37 and 54% over a short 3 years. So wildly successful. Now, with these policies, I've just extended the graph here. Spain doubled their donation rates in a decade, but following that, they stagnated again. And the issue here was that their donor pool was being reduced due to changing epidemiology and improvements in public safety. So this was actually a good thing. They were seeing less deaths from strokes and road accidents. Aggressive neurosurgical interventions such as decompressive craniectomies were reducing the incidence of brain deaths in the ICU. And as a consequence, more patients were dying from circulatory deaths, and they couldn't be donors without an established program. So Spain already had, the highest conversion rate of potential donors and the highest donation rate in the world, but they set out to do even better. And they launched this ambitious plan to exceed 40 donors per million persons. And there were really three main approaches within this plan. And we'll review each of these that will form the next half of the talk. So the first was critical care for organ donation. The second was expanding our donor criteria. And the third was donation after circulatory death. And with these three programs, Spain blew past their target and has exceeded an incredible 47 donors per million persons. Okay, so let's talk about critical care for organ donation. So one thing they noticed was that some regions in Spain were actually achieving donor rates that exceeded the estimated donor pool. So think about that. And it was because their estimates were based on the number of brain deaths that were occurring in the ICU, which excludes the potential of an organ donor who dies outside of an ICU. So they set out to study this at a national level. And they found that 1 in 2,000 patients presenting to an emergency department were potential donors. Okay? Of these, about 30% were referred to the ICU, and in their existing program, 100% were considered for transplantation. But 2/3 were never referred to the ICU, and therefore died without the possibility of organ donation. Approximately half of them were greater than 80 years of age, or they had significant comorbidities, and the majority were not ventilated. So, these were effectively patients for whom care was deemed futile, and they were made DNR and died on the wards or in the emergency department. So in their new policy, when a potentially brain dead patient is transitioning to a palliative approach to care, the case is referred to a transplant coordinator, again, one of these critical care physicians, who discusses donation with the family. If the family wishes to incorporate donation into their end-of-life plans, then the patient will go to the ICU for the sole purpose of organ donation. And by doing so, they've effectively captured the remainder of these potentially brain-dead donors. And this is a process that is now embedded in local protocols, best practices, and medical education for all transplant providers. Most of these patients are greater than 70 years of age. Approximately half of them will progress to brain death in the ICU, and the median length of stay is only 1 day. It's paid for by the public healthcare system, and it's actually wildly cost effective. So look at these numbers. Society gains 7.3 quality adjusted life years per ICU bed day. The practice is well supported by families, and it now accounts for up to 1/3 of actual donors. These are what I think the key considerations are for critical care for organ donation. So we have to remember, from an ethical perspective, interventions for the sole purpose of organ donation are now being performed on a potential donor before they're declared dead. I think this is justifiable if they promote a patient's wish to become an organ donor. But if a conflict ever arises between optimal end-of-life care and interventions to preserve an organ, then end-of-life care has to take priority. And this ensures that we respect the donor first as a person and as a patient. From a health economics perspective, we have to recognize that organ donation is extremely cost-effective and resource programs accordingly. Our health system should provide dedicated funding for these programs without compromising the care of existing ICU patients. And lastly, as physicians, we should incorporate organ donation in end-of-life discussions and document this along with their code status. Remember that we respect a patient's autonomy by allowing them to become an organ donor candidate. We're now going to discuss two scientific advancements that have increased our ability to utilize donor organs. Okay, so the first is expanded donor criteria. Expanded criteria donors are potential donors who are greater than 60 years of age, or they're greater than 50 years of age with comorbidities. As we discussed, Spain was experiencing a reduction of donors, particularly younger donors. So they decided to liberate their criteria to include these older donors. And at present, the majority of deceased donors are actually greater than age 60 years. The proportional growth of these older donors is shown by this graph on the left, where I've highlighted in purple all patients over 60 years of age. If you look closely, you'll see half of them are greater than 60, and 1/3 are actually greater than 70. Now, despite a lower utilization rate for these organs, they still account for a large number of kidney, liver, and lung transplants. By contrast, in Canada, only 1/4 of donors are 60 years or older, and I think this is a potential area of growth. But what I think is even more exciting is the use of non-standard risk donors. Okay, so a non-standard risk donor is a donor that has behaviors or exposures that portend a higher risk of transmitting a communicable disease. So what we're talking about is HIV or hepatitis C. And hepatitis C offers a great illustrative example where advances in science coupled with updated criteria can dramatically increase our donor pool. And it really is a massive donor pool. Okay, so in North America, 1 in 5 deceased donors use opioids, and hepatitis infected organs have increased by 250%. In the United States, over 300 hepatitis C infected hearts are offered per year, and until recently, only 5% were being used. So, we used to refuse a donor organ if the donor was antibody positive for hepatitis C. But this term is no longer, or this criteria is no longer relevant because it doesn't differentiate a person who is not viremic, right? So you can have hepatitis C and spontaneously clear it, or you can receive treatment. And they would be antibody positive and non-viremic. Now, in this setting, the risk of transmitting hepatitis C is extremely low. It's about 1 in 500. And that really relates to, the risk of a false negative test or testing during a seroconversion period. But even then, we still have therapy, right? So if that 1 in 500 patients contracts hepatitis C, they can now receive direct-acting antivirals, which are extremely effective in eradicating the virus and well tolerated. But what I'd like to talk about is purposefully transplanting a hepatitis C infected organ into a hepatitis C negative recipient and then treating with direct-acting antivirals. And this is now standard of practice in a lot of centers, and it's well supported by science. So I've shown the Donate HCV trial. This was published in the New England Journal of Medicine in 2019. And they took 44 heart or lung transplant recipients, so thoracic organ transplants, and they were patients who were HCV donor positive, so the organs themselves were viremic, but the recipients were negative, had never been exposed to hepatitis C. They transplanted the organs, and then they treated with direct-acting antivirals for 4 weeks. And the outcomes they looked at were sustained virologic response at 12 weeks and graft survival at 6 months. So these are the results. A bit of a complex graph on the left. I'll just walk you through it. So this is the hepatitis C viral titer. On the y-axis, you have the recipient's baseline titer, and this is a logarithmic scale. And on the y-axis, the donor baseline viral titer, again with a logarithmic scale. So we'll just see where these intersect. So let's say we go from 6 for the donor baseline, and that meets on the recipient graph at around 3. So what that tells you is that when you transplant, let's say a heart or lung from a hepatitis C infected donor, immediately after transplant, there's a 1,000-fold reduction in the viral load in the recipient. And that's in part because the heart and lungs are not reservoirs for hepatitis C, such as the liver. So immediately there's a dramatic reduction in the viral load. And then you treat them with direct-acting antivirals. And you can see here, again, a logarithmic scale with the viral load on the y-axis and weeks after transplantation or weeks on therapy on the x-axis. And in this study, by 3 weeks, the virus was completely eradicated. And that's how they achieved a remarkable 100% graft survival at 6 months and a 100% virologic response at 12 weeks. But we can even go one step further. So this was a follow-up study, a single center study by our multi-organ transplant group in Toronto. We enrolled 30 patients undergoing solid organ transplant who were hepatitis C donor positive, recipient negative. And they received, again, direct-acting antivirals, but this time for only 1 week. And it was because it was coupled with ezetimibe. So this was new to me, but coincidentally, ezetimibe actually blocks viral entry of hepatitis C into hepatocytes. We looked at an outcome of sustained virologic response at 12 weeks. And as you can see, there was a 100% virologic response. So there you have it. I mean, despite pretty intensive immunosuppression and direct viral transmission of an organ that has hepatitis C in its blood, we can safely transplant Hep C positive organs and eradicate the virus within 1 week with a well-tolerated therapy. So let's consider the ethics here. And this is, again, my take. I think that exposing a recipient to a non-standard risk donor is justified, given that we have a scarcity of ideal donors or ideal organs. And so we really have to frame the risk of accepting one of these organs by the risk of declining organs. And remember that 11% of our patients will die every year on the wait list. We also have to ensure that our definition of risk is scientific. So the risk of transplanting a Hep C positive organ changes as we now have improved diagnostics and treatment. And I think one thing we learned in Toronto was that consent for these non-standard risk donors is incredibly important. And so we would initiate it very early and in a multi-step process. So at the time that they were being listed for transplantation and at the time where a potential donor became available. This allows patients to have further education, to involve their support system in what is a very personal and complex decision. The last scientific advancement, and I think the most exciting portion of the talk, is donation after circulatory death. Okay, so deceased donation is premised on the dead donor rule. And this states that a person A must be dead to donate, and B, their death cannot be caused by donation. Now, there's currently 2 criteria which can fulfill this requirement. So the first is, a permanent lack of brain function, as in donation after brain death. The second is a permanent lack of circulatory function, donation after circulatory death. Now, the most common method of deceased donation is donation after brain death. So brain dead donors, they meet a very strict criteria involving the permanent absence of consciousness and brainstem reflexes. If this criteria is met, they can medically and legally be declared dead. Then consent is obtained to donate, and if deemed suitable, the organs are procured. I'll just walk through that there. Okay, a DCD donor, on the other hand, typically has a non-survivable brain injury that usually falls just short of the strict criteria for brain death. So they're often permanently unconscious, but they might have some preserved brainstem reflexes. In this case, consent is actually obtained before the declaration of death. Then, life support's withdrawn, the patient will eventually succumb from a PEA arrest, and death can be declared on circulatory criteria. If deemed suitable, the organs are resuscitated and procured. So the key ethical difference between donation after brain death and donation after circulatory death is that in DCD, the patients actually consented for donation before they're declared dead. And maybe more importantly, in DCD, there are some interventions that occur for the sole purpose of organ donation, and they're occurring on a living person. So in Canada, these ethical considerations have been addressed, and since 2006, kidney, lung, and liver transplantation have gained by utilizing DCD organs. They now account for up to 25% of all deceased organ donations. It's estimated that cardiac DCD could increase our volumes by 10 to 30%, but so far it's been limited by some technical and ethical issues. Well, I'm really pleased to report that cardiac DCD is now technically feasible due to advances in organ resuscitation, preservation, and evaluation. So as an example, what you're looking at is an ex vivo perfusion system, which is what we use in cardiac DCD. So I want to drill down the process a little bit more because it is quite different than liver, lung, and kidney, both in terms of the technical aspects as well as some of the ethical considerations. Okay, so in principle, death is defined as a permanent loss of brain function. A DCD patient does not meet this criteria. But we know that 5 minutes after no antegrade blood flow, circulatory failure in this setting is permanent, and it will in turn result in a permanent loss of brain function. Okay, and there's two reasons. Number one, we know that the perfusion to the brain will not be restored, will not occur spontaneously due to autoresuscitation. And blood flow to the brain is not going to be restored by medical intervention because they've ethically and legally refused resuscitation of blood flow to the brain. So therefore, their progression of brain death is permanent. Now, the ethical tension arises when we reanimate the heart and resume circulatory function, right? Because they're no longer dead by circulatory criteria. But so long as we ensure that the brain is not perfused, the loss of brain function remains permanent. So effectively, the donor now meets criteria for brain death. The organs can then be resuscitated and procured. And this approach is actually evidence-based. So this is an excellent paper that was published by Sunny Dhanani and the Canadian Critical Care Trials Group. It was published a couple months ago in the New England Journal of Medicine. And so they observed 480 patients who were undergoing a planned withdrawal of life-saving therapies in the ICU. Each of them had continuous monitoring of ECG and arterial waveforms, so they had an art line in. And they basically monitored them for 30 minutes after they had no antegrade blood flow. Okay. Now they found that only 67 of them resumed cardiac activity for a brief period of time. And in half of these cases, it was actually just one cardiac cycle. But when they looked at when the resumption of cardiac activity occurred, they showed that the majority of them occurred within the first 2 minutes, and all of them occurred within the first 5 minutes. So in summary, out of 480 patients, nobody, not one, resumed cardiac activity after 5 minutes of circulatory arrest. Therefore, a standoff time of 5 minutes supports the identification of a permanent loss of circulatory function. Okay, so now in this DCD process, you've now made the declaration of death by circulatory criteria. The next step is how we procure the organs. And there's two ways that you can do this in cardiac DCD. And there's some really important differences between the two. So the first method, direct procurement. After the declaration of death, the heart is procured. So the chest is open, the heart is procured. It's reanimated ex situ using the organ perfusion system, which I showed the video of. And there it's evaluated for its viability and suitability for transplantation. So if it's deemed suitable, it will go on and be transplanted. In the second method, regional perfusion, after a declaration of death, the cerebral circulation is cross-clamped. Then the heart is reanimated in situ using ECMO. And you can actually even wean ECMO, so the heart is beating on its own in the potential donor. The heart can then be evaluated in situ, and if it's deemed viable, it can be procured and transplanted. From an ethical perspective, the major difference in methods is that the first restores a beating heart out of the donor, whereas the second restores the beating heart inside of the donor. And both methods are actually used in practice. Okay, so the two big centers are Papworth and St. Vincent's in Australia. So in Papworth in the UK, they used a combination of direct procurement and normothermic perfusion or regional perfusion. And they published their series of 50 patients, and they showed a remarkable 100% 30-day survival. Remember that surgical complications or surgical death occurs within the first 30 days. St. Vincent's in Australia only does the direct procurement method, and that's due to their local laws. And they published on 43 patients showing a remarkable 98% one-year survival. So that actually outperforms heart transplant on the whole using conventional methods. And in the United States, the DCD Heart Trial is underway. So they've actually completed enrollment of 180 patients, and we anticipate those results in December. So regarding DCD heart transplantation, I think number one, the intention is key here. The patients expressed a wish to donate their heart, and any action that promotes their opportunity to do so respects their wishes. Number two, the method of cardiac DCD remains controversial, with some being uncomfortable restarting the heart in the donor. Personally, I think that ethical tension is resolved. And number three, the science supports it. This can result in viable organs for transplantation, and it will lead to more lives saved. So we've gone over the policies and scientific advances that I'd like to discuss. And I think we've raised some difficult legal, social, and ethical questions along the way. We have to continue to reevaluate our policies and adapt to changes in medicine and society. And it's through policy change and scientific advances that we can increase our potential donor rate, that we can increase our rate to reach our potential, and I think in turn support more acts of altruism while improving the health of society. So with that, I'd like to thank you for your attention, and I'd be very happy to answer any questions.
Thanks, Omid. That was fantastic. It was great. Why don't you check the chat there that there's a number of comments, and while you do that, let me ask you, so what is the basis for the ethical discussion with DCD? Why are people not supporting this on what ethical ground? That you're reviving someone that's dead, or what's the background there?
Yeah, that's a fantastic question. I think there's an inherent discomfort with the process as we become familiar with it. I think most people in the field feel that is now resolved, but there's certainly a bit of a knee-jerk reaction when an uninitiated or unexposed person is presented to this. The second thing is that there are laws that I think are maybe a bit antiquated that are really, well-intentioned, so meant to protect persons and potential donors. And so those are things such as, in Australia, you're not allowed to perform any interventions on an individual for the purposes of organ donation until they're declared dead. And so that's, for example, why they use direct procurement there. So, to answer your question, I think part of it's discomfort. Part of it is that we are now changing our laws and our own ethical considerations as we recognize that, the default should be that a person who wants to donate their organs should be allowed to do so. And any ethical, and as long as it's ethical, any legal barriers should actually be adapted to align with that. And I think we're just in that process right now.
So in a sense, the definition of death also needs to be kind of updated by society and the law.
Well, that's a great point. So the first heart transplant was actually DCD. So it was someone had a catastrophic motor vehicle accident, and they procured the heart and transplanted it in South Africa. And it wasn't until a couple years later that the definition of brain death actually came out. And so it was a few years ago that that we reached the 50-year mark for us having a definition of brain death. And there are calls to revise that. There are also some, which I didn't get into in this talk, but maybe just some food for thought. So I think DCD is now well established ethically and legally. Some of the other things that we are adapting to are donation after MAID, so medical assistance in dying, which is in practice and I think should be supported. But some have even asked, you know, in the process of MAID, it's still done by DCD. So you receive basically a person would receive a lethal injection, and you would have to wait until there's cardiopulmonary arrest, no antegrade blood flow, and proceed through this standoff time. And the issue there is that the individual's organs are becoming ischemic and deteriorating during that time frame. And so the question has been asked, and I'll purposefully not answer it during this talk, but the question has been asked that if I'm an individual that is undergoing MAID, and one of my last acts is I would like to donate my organs to help others, and I'd like to ensure that my organs are in the best possible condition, why would you have to wait until they suffer a long ischemic time and are potentially unusable? And it's interesting because when you survey families of persons who they had decided to donate, but they didn't progress to death in time, and so the organs were not usable, the families actually experience that as a second loss. It's devastating for them because that might have been, you know, one very important and positive act of good that would have come out of, you know, a tragedy for their loved one.
So why we haven't adopted the opt-out policy? What's the holdup there? What do we need to do for that?
Well, I think I'm not sure there's a holdup. I think it's complicated. There's an initial desire to maybe do that, thinking that it would increase transplantation rates. But I do want to stress that it has never been shown to increase rates of transplantation. It simply makes it look like society is willing to donate. So I think, you know, it's definitely not a silver bullet, and investing a lot of our efforts in that one move, I think, is maybe misguided. One thing that we have to keep in mind is that irrespective of a donor's wishes, the family is approached after organ donation. And so about 10 to 15% of the time, you might have an individual that has actually expressed a wish to donate. They may have actually registered donation. And after they die, when the family's approached, the family may say that this is not within their wishes or not within what they think their loved one's wishes were. That occurs 10 to 15% of the time, and we will not proceed. So in a way that violates the individual's autonomy. It's what's called a soft consent policy, and that's what's practiced in Canada. Part of the reason we do that is that it's extremely important to maintain the trust of society on the whole. So, you know, the way we look at it is any discussion we're having with an individual or with the family is really a discussion with the broader public. And so if there's ever a perception where organs are being procured against someone's wishes, that would be catastrophic for the field and for ethics. So I think when you look at, you know, a default assumption that someone has, you know, wishes to donate, it doesn't actually involve any action on their part, and it's kind of it can be misleading, right? So I'm not sure, as even someone that really champions organ donation, I'm not sure what an absence of an action would mean if, you know, someone has an implied consent. I'd far rather have a purposeful discussion and have that discussion documented. I hope that answers your question.
Yeah, okay. So did you look at the chat there for some of Dr. Scott Douglas's thoughtful comments there? And then
sorry,
there's
pull that up here.
There's a couple of questions on One is a tough one. What are the roles of religion and belief and social economic factors? How do they affect worldwide organ donations?
Okay. Sorry, so why don't I start with Dr. Scott Douglas. Thank you for the comment. I'll just read this aloud so everyone knows the question. Dr. Andreas Kramer, who is lead for organ transplantation, has proposed a model similar to the Spanish model. We as physicians need to support this initiative. The average cost on hemodialysis is $100,000 per year. This drives the cost effectiveness, not to mention the huge cost of keeping a heart failure or liver failure patient alive. It is far past time to have a fully funded Alberta transplant program. The current model of 2 programs discoordinated is a real problem. A provincial program exists, and it is non-functional due to no funding. Well, that wasn't a paid comment. I completely agree with everything you mentioned, so thank you for that. Yeah, I think it's incredibly important for all of us to recognize that, you know, there's so much good that comes from organ transplantation, both to the recipient, donor, and to society. And one of the goods is that it is cost effective. So that's really important. Rob, Dr. Miller, oh, sorry, there's another one. Dr. Mikhail says, what are the roles of region/belief and socioeconomic factors affecting worldwide organ donations? Oh my goodness. Well, that is probably that's a very complex question that I assure you I cannot answer. But I do think that, I hope that in highlighting, for example, compensation for organ donation, I've illustrated some of the challenges that other countries have faced, in part due to religious beliefs, and how they've tried to overcome it. Dr. Miller, great talk. You've outlined some methods to increase the donor pool. However, this doesn't help if organs aren't accepted due to concerns regarding quality, such as age, left ventricular hypertrophy, and low ejection fraction, and end up not being used. How can we make better decisions about accepting donor organs? Well, that's a great question, Dr. Miller, and I think that's an evolving science. One opportunity that's born out of this, these advancements, is the organ care system, the Transmedic organ care system, so the ex vivo perfusion system. So you'd potentially be able to, you know, the challenge is that when a donor is declared brain dead, let's say, the organs go to the ODO, and they're offered to all the different organ groups. So liver, lung, kidney might say, yes, we have an acceptable recipient, and there's a clear need to proceed. And one of the challenges is that we often see neurogenic stunned myocardium, so the LV might be a little decreased. We know it'll get better, but it's you're hard pressed to transplant a heart with an ejection fraction of 30%. Meanwhile, the family wants to proceed with organ donation, and the other organ groups would also like to proceed. So that's where something like the organ care system, it would allow you to procure the organ, resuscitate it, and observe it ex vivo to deem if it's viable for transplantation. And this is widely done in lung transplantation. In fact, in Toronto, the group there had actually performed uncontrolled DCD. So that basically means there's a motor vehicle accident or a catastrophic injury, and in an unplanned environment, after a person's arrested, if they wish to proceed with donation, they would procure the organ, resuscitate them ex vivo, and then transplant them. Dr. Mikhail, question, heart transplant in childhood? Yes, that is absolutely performed. The outcomes are excellent, and we look after many of these in our adult programs. Dr. Scott Douglas, I hope, Carlos, do we have time for more questions?
Yeah, go for it. You still have 6 minutes, so.
Okay, I'm sort of motoring through these, so if you guys have any follow-up questions, please just interrupt. So Dr. Scott Douglas asks that I understand the discussion of donation after MAID must be initiated by patient and is not initiated by the MAID program. Maybe it should be standardized into the consent program. I'm not a MAID practitioner, and while I've tried to familiarize myself with the protocol, I'm by no means an expert. The one caution or caveat I would have there is that I think the option for transplantation should only be presented after there's clarity that they are, without any coercion or additional incentive, have decided to proceed with MAID. So that ensures a clear separation between their decision for MAID and the decision for transplant. Dr. Raj, why does opt-out not increase transplant rates? Is there a problem that could be fixed? Well, thanks for that question. I think that an opt-out policy, it increases consent rates, but as we've highlighted historically, it has not increased transplant rates. And the major issue is that it's maybe somewhat of a misguided as a silver bullet, and it really has to be coupled with infrastructure and appropriate support for transplantation for it to work.
I guess that's what the Spanish program showed, by increasing their per million number. It's not only the opt-out, but also the infrastructure and the coordination and all that stuff they did.
Well, you're absolutely right. I would like to, Dr. Schnell asked an excellent question. Well, they've all been excellent, but this question is, having gone through a number of DCD cases where organs were not successfully procured, it can be frustrating for family and caregivers involved to have to wait for the absence of cardiac electrical activity. And I would add it's actually the absence of a 5 millimeter increase on the arterial line, so complete flat line on the arterial line. I support the new changes in the declaration of circulatory death with removal of the absence of electrical activity if the patient has an arterial line. Yeah, that sounds wonderful. I want to follow up with just a few slides that I have just to, oh, I think it's here, DCD. Okay, so these are quotes when they surveyed families of persons who had loved ones that didn't progress in time to participate in DCD after they've already said we would like to engage in DCD. So they said you would have felt like she died, sorry, you would have felt like she kind of died with a purpose, and they were denied that. People could have been saved, potentially. There was people that died because his organs weren't able to be donated, and all of the other people that could have had a quality of life. Okay, so that's the impact. And the one thing he wanted to do most with his life, and it would have been something that I know he would have loved to have done, because like I said, he had a pretty tough life. And this was the final thing that I think would have made him happy. Now, when you look at, now I've anonymized this, but this is a graph of hospitals in Canada. And this is a number of cases of planned or intended DCD. And in the red, these are patients that were transplanted, and in the blue, these are patients.
You're not sharing the slide, so we can't see it.
Oh, really?
Just share the slide, yeah.
Are you guys able to see that or no?
Nope.
Okay, sorry. Let me. Well, I haven't been sharing my screen for a while. Apologies here. Okay, can you guys see that?
Yep.
Thanks, Carlos. So, so again, a graph of DCD donors who did not die in sufficient time. These are Canadian hospitals, and I've just anonymized it because the locations are relevant. But in red, you can see the patients that were transplanted because they died in time, and in blue, they did not die in time. So just look at the variability. I mean, some centers have, 75% of patients not progressing for DCD in time. Versus others, such as the second from the right, have maybe 90% of them are progressing in time and being transplanted. And so you can imagine what the issues there are, and it often relates to the bedside end of life care, how much sedation is being given for comfort, what the even when the patient is extubated, where they legally and
some standardized quality improvement is needed there.
Yeah, and and you can appreciate the sensitivities around this, but even things such as when a patient is extubated and they wish to progress to death to donate, are they left in a typical jaw thrust position by an RT, or are they left in a normal head neutral or even head down position? So these actually make a big difference in the person's outcome. I won't speak more on that. It's obviously a contentious area, but you can see you can see that the impacts that this has on the families here from these quotations.
Well, it's 9 o'clock, so yeah, it was a great talk. Very insightful and well evidence-based. So congratulations, and I think we should all congratulate ourselves that we've been able to hire you into our team. So that is also a great achievement for all of us.